Hello and welcome to this program provided by the France Foundation and the Kidney Cancer Association. This program is titled Immune Checkpoint Inhibitors in Renal Cell Carcinoma, Where Are We Now? My name is Pedro Barata. I'm a medical oncologist at Seidman Cancer Center in Cleveland, Ohio. It is my true pleasure to be joined by key opinion leaders and who are here, Tian Yang and Kiran Virde. Please introduce yourself, guys, and welcome.
Hi, Pedro. Great to join you today. I'm Dr. Tian Zhang. I'm an associate professor at UT Southwestern Medical Center, the Harold C. Simmons Comprehensive Cancer Center. Really great to be on today.
Hello, everyone. My name is Karen Verdi. I'm an office practice registered nurse, and I work at Memorial Sloan Kettering Cancer Center in New York. Thank you for having me here.
Great, fantastic. Welcome, and I'm looking forward to our conversation. And the learning objectives for today are to review immunotherapies and therapy combinations for the management of both malignant RCC, renal cell carcinoma, and also adjuvant treatment. We were looking forward to select appropriate immunotherapy agents for patients with RCC based on the individual patient characteristics and needs. Also, we're going to focus on monitoring RCC patients receiving immunotherapy for adverse events. And finally, how to manage those adverse events in a timely fashion for RCC patients who are receiving immunotherapy. And with that said, I'll pass the baton to Dr. Yang to start with a clinical case.
Great. Thanks, Dr. Barata. Here's our case to start. He's a 70-year-old gentleman who presented with gross hematuria. A CT showed a 13-centimeter right renal mass with hemorrhage into the ureter and bladder, and he underwent a right radical nephrectomy and on pathology showed a clear cell renal cell carcinoma 11 centimeters with extensive involvement of the renal vein, renal sinus fat with rhabdoid and focal sarcomatoid differentiation, as well as multifocal tumor necrosis. The margins were negative, so he was pathologically staged as PT3A and XMX disease. So we come to our first pretest question. Which of the following would be the optimal choice for a patient who wants medical therapy after nephrectomy? And I'll turn it back over to you, Dr. Barata, for discussion of Keynote 564.
Great. Thank you, Dr. Young. And this is a perfect, segue for us to go through the adjuvant data. And I should really start with the Keynote 564, an important phase 3 trial that that read out, and I think it provided us very important information. But first things first, let's go through the study schema first. In this trial, patients with histologically confirmed clear cell renal cell carcinoma with either intermediate high risk, or post-metastasectomy were randomized in a 1-to-1 fashion to either 1 year of pembrolizumab at a standard dose 200 milligrams every 3 weeks, or placebo also for a year. The primary endpoint was disease-free survival per investigator, and then we had very important secondary endpoints such as overall survival and safety. And we had a median time, from randomization to cutoff for about 30 months or so. And let's get started with actually the secondary endpoint, overall survival. Here's the survival curve here for the intention to treat population. I should remind us that is actually immature at this point. Nonetheless, we do appreciate at time of the cutoff analysis an hazard ratio of 0.52 or a 48% risk reduction, favoring the group of patients treated with pembrolizumab for 1 year compared with placebo. Additionally, we can appreciate the disease-free survival by recurrence risk subgroups. So we have the breakdown, intermediate high risk on the left, high risk, and then post-metastasectomy. And what's interesting to see here is a couple of things, right? First, we do see significant, different favoring longer disease-free survival for patients treated with pembrolizumab in all of these subgroups. What is interesting is the different hazard ratio or the risk reduction in the disease, in the time to event, compared in the intermediate high risk population, an hazard ratio of 0.68 going down to 0.6 for the group of patients with high risk, and finally 0.28 for patients post-metastasectomy, all of them favoring, again, the adjuvant pembrolizumab 1 year compared with placebo for 1 year. And I think that's very important to note. So I guess when we put all these data together, we know that the Keynote 564 data, it's not alone. In other words, we had data that's been reported thus far with other important phase 3 trials. And I'm thinking about, the Prosper trial, which actually asked a question about the role of nivolumab, a little bit of nivolumab pre-surgery and followed by nivolumab adjuvantly. And then the Emotion 10 that basically had a similar study schema design, asking the question about the role of adjuvant atezolizumab compared to placebo in the adjuvant setting. And we have a number of other studies. I think the Checkmate 914 had three arms, but one of the arm was actually, the arm comparing an EP-Nivo for 6 months compared to placebo. That was the cohort A. And so all those trials that we've seen results from actually are going opposite direction compared with the Keynote 564. We're really thus far the first clear positive trial favoring the use of adjuvant pembrolizumab in the adjuvant setting for patients with clear cell RCC. So maybe I should, Dr. Zhang, it's a good opportunity. Let me ask you, what are your thoughts about, when you saw these data being presented, and what are your thoughts? You knew the data from Keynote 564, and now you saw data from Prosper, Emotion, Checkmate 914. I guess, what are your thoughts about that? And, and by the way, what are your thoughts about the studies that have not read out yet?
Sure, Dr. Barada, we all accrued a lot of patients to all of these trials, and I think they're meaningful, even though they didn't reach their primary endpoint. I think even negative trials have a lot to teach us once we delve into the data and do the correlative studies. So I think it's really important still, regardless of whether they met their primary endpoint, to go back and figure out why. And a lot of us are applying what currently we know from circulating tumor DNA, for example, or tissue analysis to these specimens from these trials to try to figure out why these trials were negative and what patient characteristics actually leads to high-risk disease to need adjuvant treatment. That said, there are 2 ongoing adjuvant trials. One is called Rampart with treatment of durvalumab with or without tremelimumab, the CTLA-4 inhibitor versus active monitoring. So that's ongoing. And then the LightSpark 022 trial is also ongoing accruals with randomizing to an active control cohort, pembrolizumab versus pembrolizumab with belzutifan combination. So I would note that LightSpark 022 is the first adjuvant trial to have an active control cohort with pembrolizumab. So I think all of these trials will teach us, and hopefully with the ongoing accruals of the 2 Rampart and LightSpark 022, we'll learn even more. Excellent. So back to our case. As you'll remember, our 70-year-old gentleman presented with gross hematuria, and he had undergone a right nephrectomy with pathologic T3A and X disease. He opted for surveillance. These were the days where we did not have pembrolizumab approved. And 10 months later, on surveillance scans, he unfortunately developed multifocal bilateral pulmonary nodules that you see here on the cross-sectional CT images of his lungs. His labs were normal, including calcium, hemoglobin, white count, and platelet count. And he had excellent performance status. So here we'd love to discuss the latest evidence-based management for first-line metastatic renal cell carcinoma. And we'll start with a pretest question. Which of the following is a recommended option for a patient with previously untreated metastatic clear cell renal cell carcinoma with intermediate risk, 1 risk factor? All right, and I'll turn it back over to you, Dr. Barada, to take us through the treatment landscape.
Wonderful, thank you, and a very provocative question, Dr. Zhang. Thank you so much. So, and as we've been talking about, this great problem to have when we start having slides addressing the treatment landscape becoming really busy, right? And we can clearly see that on the right side of the schema with a number of novel therapies and novel combination regimens approved for patients with advanced renal cell carcinoma. And so there's a lot of movement, a lot of new data to dissect, and a lot of thoughts that we have about when to do what. And hopefully we'll go through that in the next portion of this program. When we think of the frontline treatment options for patients with advanced renal cell carcinoma, I guess one way to present those options is to break down by, I guess, mechanism of action, right? So we started, with, and actually on the right side of this board by thinking that the TKI monotherapy has been the established standard of care for a number of years, right? We had data not only with sunitinib and then with pazopanib shown to be equivalent to sunitinib, and more recently with cabozantinib, who have suggested to be superior to sunitinib based on a prospective phase 2 trial. And in other words, we did have these, target therapies, angiogenic therapies became the standard of care. And the question afterwards, with the emergence of different checkpoint inhibitors, first in the refractory setting with nivolumab, the question was, what if, we would explore the role of checkpoint inhibitors in the front line? And that was done, either combining two different checkpoint inhibitors, and we do have a good example of that with ipilimumab plus nivolumab, a CTLA-4 inhibitor with a PD-1 inhibitor, and then we also combine a checkpoint inhibitor with a VEGF therapy, and that's we have a number of combination strategies who did that. We're thinking about we started first with axitinib, avelumab, axitinib, pembrolizumab, and then more recently cabozantinib, nivolumab, and lenvatinib, pembrolizumab. So we have different, checkpoint inhibitors, PD-1 and PD-L1 inhibitor combined with different, anti-VEGF therapies, axitinib, cabozantinib, lenvatinib, again in the frontline space. And so when we look at all the options now, we have this, thought process of should I go with a IO approach, or should I think of an IO VEGF approach, or do we have a patient really suited for a VEGF as monotherapy? Dr. Jiang, we have a number of options, and maybe before we go further in this program, maybe do you want to share a couple of general thoughts? Is that what you think when you're seeing a patient in front of you in clinic? Do you happen to find yourself more often going towards one option versus the others? What are your thoughts about that?
Yeah, no, it's a great question. Now that we have multiple immunotherapy-based options approved in the frontline setting, I think it's worthwhile to note that none of these have been directly compared to each other for the immunotherapy combinations. And so I use them all in my clinic, and I think about patient risk factors when they're presenting in clinic with newly diagnosed metastatic renal cell carcinoma. I would say that I generally would use Nivo and Ipi for patients who are not severely symptomatic, and I tend to favor a more VEGF IO approach, either axitinib, pembrolizumab, cabozantinib, nivolumab, or lenvatinib, pembrolizumab, in situations where patients are more symptomatic or they have a higher disease burden and need earlier disease control. But I tend to use all of these combinations, and I think patients can really think about each strategy and the outcomes that they're interested in.
Got it. So it's actually a perfect segue, because what I'm going to ask you next is if you can share with us a little bit more detail about all these trials.
Absolutely. Thanks. Absolutely. Happy to highlight these frontline immunotherapy combination studies. I would note that the primary endpoint for all of these studies in the earlier settings, so the nivolumab, ipilimumab, pembrolizumab, axitinib, and avelumab, axitinib, were really co-primary endpoints around progression-free survival and overall survival. As we got into the later trials, the nivolumab, cabozantinib, as well as pembrolizumab, lenvatinib, these trials hovered around progression-free survival as the primary endpoint. And here you see the baseline patient characteristics for the patients who were enrolled on these trials. Of note, I would say that there were hundreds of patients who gave their data to this, and thousands of patients who gave their data to these trials. And really, we have learned a significant amount about immunotherapy combinations through their generous efforts. But I would note most of these patients had intermediate or poor risk disease in all of the trials, with only about 20 to 30% having favorable risk disease. As we got a little bit further into the novel era, so the older guard, if you will, of the immunotherapy and combinations, Checkmate 214, Keynote 426, and Javelin 101 had around 80% patients with prior nephrectomies. With Checkmate 9ER and Clear, these trials really were ranged around 70% for patients with prior nephrectomies. And this is important because we know that patients who have de novo metastatic disease, those who have not had a prior nephrectomy, are more likely not to have a complete response, particularly in their primary renal tumor. And then you'll see the PD-L1 expression levels here range from 25% on the nivo with cabozantinib and nivo-ipi trials using the DACO PD-L1 testing to up to 60-some% using more the Ventana PD-L1 testing and cutoff characteristics. So for now, PD-L1 has not been one of the biomarkers that I'm using in clinic for treatment selection. Next slide. And so here's the summary of our immunotherapy combination trials in terms of efficacy and outcomes. As you'll see, the longest follow-up that we have is with the Checkmate 214 trial, 67 months median follow-up. So these patients are out 5 or more years, and we're seeing some of the data here. So very accurate data long-term. The median progression-free survival for a pure immune checkpoint inhibitor combination is about 12 months. This was not statistically significant, but the median overall survival was improved compared to sunitinib at 56 months with a hazard ratio around 0.72. And the objective response rate, we'll note kind of coming across that for nivo-ipi was actually not as high, around 39%, with 12% of those being complete responses. As we then tackle the VEGF-IO combinations, these all had median follow-ups around 2.5 to 3.5 years as the last check-in, and you'll see median progression-free survival hovering around 15-16 months for pembro-axi and nivo-cabo combinations, around 24 months for the pembro and lenvatinib combination, and these progression-free survival hazard ratios were statistically significant. The median overall survival for Keynote 426 was around 45 months, and for nivo and cabo on Checkmate 9ER was 37 months. For pembrolizumab and lenvatinib on Clear, this was not yet reached, but you'll see these hazard ratios all range in the low 0.7 range, and these are statistically significant compared against sunitinib as the control cohort. And as I mentioned previously, I do favor these VEGF-IO combinations because they offer a little bit more disease control and objective responses. You'll see objective responses here are ranging 56 to 71%. So most patients will achieve some tumor shrinkage. we'll take you back to our case now. This was our 70-year-old gentleman who had surveillance scans showing multifocal bilateral pulmonary nodules. His labs were checked. He was a little bit anemic, and this was within a year of his nephrectomy, and therefore he went ahead and started ipilimumab and nivolumab. All right, I think we're getting into our hypothetical situation here with similar patient characteristics of 70-year-old man with a recurrent clear cell renal cell carcinoma with sarcomatoid and rhabdoid features, metastatic now to lung and the liver. He is now symptomatic and has both anemia and hypercalcemia. So what would be our preferred treatment option in this setting now that he is symptomatic? Dr. Barada, do you want to start? And also Karen would love to hear your thoughts.
Absolutely. And by the way, thank you for that fantastic overview, because it really helps us to put the data into context, right? So when I look at cases, and we have cases like this every day in clinic, it's important to break it down, right? So when I would, let me share my thoughts about this case. First is obviously we're talking about a patient with advanced clear cell for most of the data that you presented, Dr. Zhang, applies to. So I think that's important. The other perspective has to do with the other point of the pathology, if you will, which is actually the fact that he has sarcomatoid rhabdoid features present. And I think that's tremendously important, because all these IO-based combos have shown to do particularly well for clear cell histology in the presence of sarcomatoid rhabdoid features. So if there's any predictive marker of response to an IO-based approach, I think the presence of sarcomatoid and rhabdoid features is just that. And I think that's really important. So to me, that would definitely make me think of an IO-based approach for this patient. In addition to that, I think location of mets and symptoms is really, really important, right? We all know that, mets in the liver or the bone, CNS, those patients tend to do poorly, right? And in addition to that, this patient is symptomatic. He's really sick. And so it gives us the sense of urgency, right? And so in clinic, when I have a patient like this, the thought process that I usually have is, whatever I'm going to do, I want to make sure I take all the chances that whatever I do is going to work, is going to be effective, and I'm going to minimize the chances of not being successful, because it might be the only chance of treating this patient with advanced RCC. So with that thought process in mind, I usually think of what combos are out there who give me the lowest number of progressive disease as best response, as it's usually an IO-TKI, right? I'm thinking Cabo-Nivo, I'm thinking Lamf-Pem, for example. If even Axipemba, we're talking between 10% to actually 5-6% of progressive disease. In addition to that, the highest response rate that we've seen is usually an IO-based approach, IO plus a TKI approach, and we're talking about 60 to 70% range as far as overall response rate. So for a patient that's symptomatic, a lot of disease in worrisome spots, I tend to think that an IO-TKI is a good way for me in clinic to address those cases, because I know that, I'm likely be successful controlling the disease. Hopefully we'll shrink it and the patient will start getting better. And by the way, the time to response is really, really short, which means a lot of times patients start feeling better, not many weeks after they've started on that approach. So that's kind of my thought process. Now, with that said, I do think it's reasonable to think of Ipi/Nivo as an approach for this patient, because this patient, has intermediate risk, I believe, RCC. In addition to that, has sarcomatoid features. So there's also good data suggesting that patients with sarcomatoid features benefit the most from Ipi/Nivo. So, but that would be my probably way of practice, in clinic if I had a patient like this.
Yes, Dr. Brada. Given I agree with your suggestions. I think given that the patient has sarcomatoid features, it would be appropriate to start the patient on an immunotherapy, either with ipilimumab, nivolumab, or lenva pembro in this scenario. The one thing that I would suggest or recommend when we start patients on any sort of treatment is to complete a thorough health history on the patients, especially with immunotherapy, to identify if they have any pre-existing autoimmune conditions that may be exacerbated once they start treatment. If we start patients on any TKI combination as well, to also ensure that they, may not develop any worsening toxicities if some patients have uncontrolled hypertension and then we start them on lenvatinib, it could also, kind of exacerbate that. So just really doing a thorough health history prior to starting patients on the specific treatment regimen.
Great. I think those are really wonderful points from both of you, and especially for early disease control for symptomatic disease, as well as looking for comorbidities and anything that we would hesitate to start one of our treatments, Karen. So I think with that, we can segue to our next portion.
Fantastic. Thank you so much. And, and I'm really happy we brought up the point about, Kieran brought up the point about, tolerability, and with checkpoint inhibitors, right? Because, we have been talking a lot, and going through the data regarding the activity of these strategies. But the question is, what about the toxicity? And I think that's very, very important. And so just to go briefly through it, we do have the breakdown here. Each column represents the trials that we've been alluding to: Ipi/Nivo for the CheckMate 214, the Axi/Pembro for Keynote 426, Cabo/Nivo for CheckMate 9ER, and Lenv/Pem, or lenvatinib pembrolizumab with a clear study. We can see that, actually, treatment-related adverse events are not infrequent, right? They happen in more than half of the patients, with ranges between 48-50% to over 80%. So this is a reality, and when we're treating these patients in clinic, we are expecting them to develop adverse events, and grade 3 and means and above. That means significant adverse events, if you will. I think of them, we have to be prepared to know exactly what to do. We have to recognize them. We'll talk about them a little bit later. But in some circumstances, it does require discontinuation of the therapy, either one of the cocktail of the combo, or actually both of them, right? And we can see about a quarter of patients end up stopping the therapy, either the TKI or the IO or IO for the Ipi/Nivo case in the presence of treatment-related adverse events. The other perspective is regarding the use of immunosuppression. We tend to be using steroids frequently, and actually, what you can see from this board, if the use of the high-dose steroids, meaning 40 milligrams of prednisone equivalent daily, right, and that actually happens in a number of patients over 21% or so, which means we have to be comfortable using immunosuppressive therapies when we're dealing with these IO-based approaches. And sad to say, it's not frequent, but it can happen. Unfortunately, the grade 5s, the toxic death caused by these IO-based approaches, it's a reality. I think the way to the number is not high, but it does range from 0.3% to over 4%. And I guess one way to minimize that is actually the fast identification of those adverse events, immune-mediated adverse events, and a rapid management of those adverse events is probably the way to bring that number down. All right, and kind of side by side with the safety and tolerability of these agents is actually an important piece of data that comes out of these phase 3 trials, and it has to do with quality of life. Now, the quality of life data is such an important topic. We're talking about the different treatment options for patients with advanced renal cell carcinoma, but it's also a very difficult topic to address. And part of the reason is because we do have different quality of life instruments who have been validated and being used in these different trials. So again, for the different trials here represented in each column, we have the different instruments used in the different trials, and you can see we didn't necessarily use all the same instruments in all single trials. And the other aspect that I should mention is we actually tend to apply these questionnaires to patients in different time points, and so that and all that leads me to say that it's very difficult to do head-to-head comparisons. But what we can do is actually look at what trials perform, or the combination perform, against sunitinib, because sunitinib was the comparator, the control group in all these trials. And so what I think it's interesting here is, I guess, the common theme is actually from the quality of life perspective. Patients treated with an IO-based approach, whether it's Ipi/Nivo or Axi/Pembro, Cabo/Nivo, or Lenv/Pem, did not do worse than patients treated with sunitinib. They might have done similarly, if not better, than patients treated with sunitinib. And then, it is true that for the CheckMate 214 and the CheckMate 9ER, meaning the trials with Ipi-Nivo and Cabo-Nivo, if you will, patients treated with a combination regimen did better from the quality of life instruments used compared with sunitinib in that respective trials. And then with the Axi-Pembro data and the Lenv-Pembro data, we did see equivalent quality of life in some circumstances, a little bit better. But again, we go into the more difficult scenario of comparing across studies, and I don't think we really can do that. But what I think is important message is, in addition to these combination regimens have shown a survival advantage, meaning patients will live longer, we now have quality of life to support the statement. Actually, patients do the same, if not better, on the different IO-based combos compared with TKI monotherapy sunitinib. To put this together, as we all go and look at the guidelines as a way to reflect what level one ideal level one data tells us, and so we derive the guidelines come from the prospective data that we are able to generate from prospective phase 3 trials. And so here, as you can see, for frontline therapy for clear cell RCC, we do have a breakdown based on risk. So I think we stress out enough the importance of the risk category. Whether you go with favorable risk or poor intermediate risk, we have different options available because we enroll patients differently based on that. We have preferred regimens, all of them based on category 1, Axi-Pembro, Cabo-Nivo, Lenv-Pembro for favorable risk, IO-TKI combinations. For poor intermediate risk, in addition to the Axi-Pembro, Cabo-Nivo, and Lenv-Pembro, we add Ipi-Nivo as category 1. We do also have cabozantinib in there based on cabozan data. And then we also have other recommended regimens that can be used and considered in certain circumstances. But I would really like to highlight the data that has been or the recommendation based on category 1 evidence or phase 3 trial data. And then for subsequent therapy for clear cell RCC, we haven't spent as much time today talking about what to do upon progression. Unfortunately, we're not able to cure most of the patients who come to see us and are offered a frontline approach. We do have different options that we can use. Preferred regimens include cabozantinib, lenvatinib plus everolimus, and nivolumab. And we also have other recommended regimens. I would highlight of the subsequent therapy regimens supported by category 1. It would be cabozantinib, nivolumab, axitinib, and tivozanib.
Thank you, Dr. Barada. So our next section that we will focus on is monitoring and managing adverse events. Our next pretest question is, which of the following adverse events is associated with treatment with immune checkpoint inhibitors? So patient education is such an integral part when we discuss managing and monitoring adverse events. As healthcare providers, it's important for us to identify any educational barriers that may come up during patient teaching, which may affect how well a patient understands when to call the office. Some patient or education barriers may be health literacy. Patients may not understand certain medical terminology as we're doing teaching with them, so they may not be aware of what does colitis mean? What does dermatitis mean? Another barrier might be their willingness to learn. In general, when we review patient teaching, it's after the patient has seen the oncologist and they've been given their diagnosis and their treatment plan. This can, of course, be a very overwhelming situation for the patient and their family. So when we come in with providing education for, toxicities, adverse events, patients may have already reached their capacity of absorbing any further knowledge for that day. So that being said, patient education is something that's an ongoing process. It's not just kind of confined to that one initial visit, but something that's ongoing through their treatment plan. It's important to also identify education modalities, what works best for a patient to learn, what adverse events to look out for. Some patients prefer everything to be given to them in writing. Other patients prefer to take their own notes. They keep a daily diary or a journal of how they're doing, which is great. So really identifying what works best for the patient. And that being said, patient education is really very an individualized teaching that is specific to the patient, and really understanding what works best for them. One method that I have found effective is the teach back method, where patients relay what they've learned during that clinic visit, so that we as healthcare providers can say that, patients do understand that this is when they need to call. These are what the next steps will be. Along in this slide as well, we have adverse events that are identified with TKI and also IO treatment regimens. There is a lot of overlap with the adverse events, specifically diarrhea, dermatitis, fatigue, and liver function abnormalities. So keeping in mind when patients are on dual or TKI-IO combination treatments, that these side effects can occur from either of the medications, and to identify which of the medications may need to be held so that patients' adverse events do improve. So some key points in patient education is really in that initial visit, given all the list of adverse events that were identified in the previous slide, it's really important to focus on the most common. And in this case, it would be colitis, dermatitis, and endocrinopathies. So really focusing on those adverse events. And then as further clinic visits go on, talking about other adverse events that may occur. It is also important to review quality of life with the patient. Patients may be fearful or reluctant to report symptoms because their first thought is that the oncologist is going to stop the treatment, discontinue the treatment altogether, and then they will not have any further treatment options or very many treatment options left. So really keeping that open communication, that as the oncologist team, that we do want the patient to continue on their treatment, but that it is very important to really identify those adverse events really at the onset as soon as they occur, so that we can treat them right away and intervene as soon as possible, so that it might not affect their long-term treatment plan. Another key point to take away with patient education is just ensuring that your patient has all of the correct contact information. Who do they call should they develop an adverse event? Giving the patient information for after hours when the clinics are closed. If the patient has treatment on a Friday evening and they develop colitis Saturday morning, who are they going to call? So providing them with that information really ensures open communication and a trusting relationship with the patient. So here we continue with the case. The patient was started on ipilimumab, nivolumab, and then after cycle 3, they developed pretty significant diarrhea 6 times per day, and then also a rash over their arms and chest. As a nursing assessment, we would, assess each adverse event with the diarrhea. When did the diarrhea start? Is there any nausea, vomiting? Are they having fevers? And in regards to the rash, having the patient come in for a skin check or sending us pictures so that we can evaluate the rash and see if there's any skin breakdown or, if further treatment is needed. And Dr. Zhang and Dr. Brado, do you have any suggestions in this specific case?
It's a really common situation, where we have some colitis and rash from ipilimumab in particular, and nivolumab combinations in the early 4 cycles. It's interesting to note that Checkmate 214 only took patients who finished all 4 cycles of Ipi and Nivo. So there were patients who didn't finish all 4 cycles. And, we know that that potentially, not everybody gets through all 4 cycles. And the hard part is figuring out how much patients need and whether they absolutely need to complete all 4. So in my practice, though, if we incur a toxicity that really limits our ability to give all 4 cycles, as in this case, we would skip cycle 4 and treat with steroids quickly and monitor how the patients are doing. If they are continuing to have diarrhea and colitis despite steroids, usually prednisone 1 milligram per kilogram. If they're having diarrhea despite steroids, then we would take off the second-line agents like vedolizumab for immune-mediated colitis. But I have no hesitancy in holding that 4th cycle of Ipi and Nivo.
I completely agree with those thoughts. That's really what I was thinking also. And maybe just to add something you guys haven't said, it's just, of course, in this case, it's more like straightforward, because we have rash and diarrhea and the patient is being treated with 2 different checkpoint inhibitors, right? And so we kind of know this is likely immune-mediated adverse events and we have to address them as such. A lot of times when we're using an IO, a TKI, right, and we're thinking about diarrhea, maybe the rash would help us figure it out. Oh, wait, this is probably immune mediated. But let's say the patient did not develop rash, only had diarrhea, because the half-life of the TKI is relatively short. We're talking about a couple of days, depending on the TKI we use. One easy approach is, in addition to treatment, to symptom management, if you will, right, optimizing antidiarrheal medication here would be to hold the TKI, and we'll get the answer pretty quickly whether or not there was TKI related or whether or not this is about colitis, if you will, which would be immune-mediated adverse event. So the reason I'm bringing that up, because there are some adverse events that actually overlap, right? When we're thinking of the different mechanisms of action, and it makes things a little bit more difficult. And but again, the more we use, the more experienced also we are with these therapies and these potential adverse events. Great, and this was a very interesting case and great bridge to what we're going to be talking next. So really focusing on the immune-mediated adverse events, right? And a way that I tend to tell my patients in clinic is, listen, we're going to, your body's going to be inflamed, right? We're going to activate the immune system that fights cancer better. That means any organ can be activated and therefore develop adverse events. So we can see that involving different organs. We can see adverse events involving the skin. We can see involving the liver. We can have endocrinology. I'm thinking about thyroid. I'm thinking about adrenal. I'm thinking about hypophysis, if you will. I'm thinking about pulmonary. I'm thinking about cardiac. I'm also obviously thinking about GI, as our case alluded to, but also musculoskeletal, right? It's common to see arthralgias and myalgias. So with that said, we should expect anything at any point in time. But I really think the time to onset is really important, because we know what to expect, right? It's not that 100% of the times it's going to be like this, but in general, when we go over the data, and this is specific data for Ipi/Nivo, since our patient was treated with Ipi/Nivo, in general, we tend to see skin involvement first, and we're talking about usually rash, itchiness, and then usually GI symptoms follow. We can have, in addition to the fatigue and nausea, we can have actually diarrhea, as our patient presented. Actually, our patient presented with rash and diarrhea right after 3-4 cycles, which is exactly where we would kind of expect some of those adverse events to happen, but also I think we need to keep monitoring those patients with blood work on a regular basis. And I'm thinking, among other things, I'm thinking about hepatitis, with LFT elevations, for example, and also the kidney toxicity, right? Nephritis is a reality, and we need to really pay attention to it. And so I personally get urinalysis every other cycle for my patients, and looking for proteinuria in addition to the blood tests that I do. But less common, but also real, is the pneumonitis, right? right? And of course, as we tend to scan these patients, we tend to do scans every 9 to 12 weeks to monitor disease response, but also we should keep in mind that symptoms related to the chest, such as shortness of breath, should trigger us to think of pneumonitis as the reality. So the time to onset is really, really important, and I think this goes way beyond ipi/nivo, right? It's actually systematic analysis of the time to onset of different the different toxicities that occur with different checkpoint inhibitors. As you can see here, we'll highlight the rash followed by the GI, diarrhea, colitis, and then we start seeing the liver toxicity, hypophysitis, etc. So it gives us an idea what to expect. Now, with that said, I should definitely highlight that we can have a patient with no checkpoint inhibitor or checkpoint inhibitor hold a year ago and starts developing new adverse events. And that's because there's not a cumulative dose for immune-mediated adverse events. They can happen at any point in time, even if the patient is off a checkpoint inhibitor. And I think that's very important, and there's a lot of education that goes with this, especially for our colleagues and friends from the emergency department, because we really need to go back to ask the question, what is the treatment that he has received for his cancer, for instance, and not unfrequently patients were treated previously with a checkpoint inhibitor a year or two ago and now present with an immune mediated adverse event. So the other perspective that has to do with what my colleagues have mentioned has to do with, okay, but since we identified them and hopefully we identify them as fast as possible, what is the time to resolution of any grade treatment-related adverse event? And again, this is data from the from ipi/nivo, from Dr. Tanier here. And I think what's interesting to see is actually, it's often it's faster for patients to develop immune-mediated adverse events than it is once we identify them actually to be resolved, right? And that we have median numbers here, expecting about, almost 3 months for rash to disappear or to resolve. We're thinking about, shorter for the diarrhea piece, 2 to 3 weeks for the GI symptoms. We have around 6 weeks for hepatic, liver toxicity, if you will. And then we have about, over 3 months for renal toxicity and about 6 weeks for pulmonary toxicity. But what's interesting is not just the median, right? It's also the range. Look how different, look at how wide the range is, right? For renal toxicity, it goes from 4 to 21 weeks. That's a big difference. So, pulmonary adverse events, right? From 4 weeks all the way to 11 weeks. So I think the message that we have here from the time to resolution is these adverse events can persist for a significant amount of time. And we have to be prepared with them. And that means some of these patients will remain on immunosuppression for quite a while. And I think that's really important as we try to manage those adverse events to understand exactly what we're expecting. And we are expecting that some of these adverse events will remain and will persist over time. And in a lot of patients, we will have to keep them on a high dose of steroids for a significant amount of time. And of course, the more comfortable we are dealing with these adverse events, the better.
So our last pretest question is, a patient developed diarrhea times 3 while on nivolumab maintenance. Which of the following would be your preferred management? When we talk about adverse events, we use a standardized tool, the grading and responding to adverse events. And this tool helps us to determine the severity of the adverse events and the most appropriate treatment. So with grade 1, a grade 1 adverse event would be considered mild symptoms, which may require supportive care. For example, if a patient were to develop diarrhea 2, maybe 3 bowel movements a day, we would probably try some diet changes and see if that helps increasing hydration. At this point, we would still continue with the immunotherapy regimen. For grade 2, we would consider moderate, grade 2 for moderate symptoms, which may require very minimal intervention, non-invasive, such as holding the immunotherapy and starting the patient on a low dose steroid, and talking about or having a discussion with the oncologist of restarting the immunotherapy once the adverse events, are now a grade 1. Grade 3 and grade 4 are significant adverse events. With grade 3, patients may need to be hospitalized at times. At that point, we would, of course, stop the immunotherapy altogether and put patients on high-dose steroids. These steroids require a steroid taper, which may be 4 to 6 weeks, sometimes even longer. At times, we do manage these patients in an outpatient setting where they're not in the hospital, and it requires frequent phone calls from the clinic to the patient, either every day, every other day, to assess if their symptoms are improving given the high dose of steroids. So keeping in mind that usually with a grade 3, treatment is stopped, and the steroids, it could possibly be a long steroid taper, and also may involve consults as well, specifically to GI or to dermatology. So for colitis, in managing colitis, the initial assessment would be, how often is a patient having bowel movements? Really, it's important when patients start any sort of immunotherapy is to determine what their baseline bowel movements are, so we have something to compare to. But the frequency of their stools, as mentioned previously, if the patient is having any nausea, vomiting, are they having fevers? Is there any blood in the stool? Are they having abdominal pain? So really kind of doing a thorough assessment on the patient. At that point, we would also do testing with a stool sample, and informing the patient to not take any antidiarrheals until the testing results come back. But the stool sample is another criteria or a diagnostic tool that we use determine if a patient has colitis. And if indeed they do, then we would start them on oral steroids such as budesonide or prednisone. And we may also put in a GI consult where they might need infusions with vedolizumab. And another adverse event is dermatitis. So the management for that would be the initial assessment, of course, is the dermatitis, is it a rash? Is it a certain part of the body? Is it localized to one area? Is it full body rash? Is there pruritus, any skin breakdown? So really doing a good skin check on the patient. And then treatment would be accordingly. If it were to be a localized rash, we would have the patient take a topical steroid and continue to monitor to see if the rash is, increasing in size. If it's a generalized rash, we do put them on steroids right away with prednisone, and then also have them see a dermatologist as well. Pruritus is very common, I've seen, with immunotherapy. It can be sometimes quite challenging to treat. We would recommend patients trying an antihistamine, using an anti-itch lotion can also help. And then sometimes we may prescribe medications such as gabapentin.
Wow, what a fantastic program. Thank you, my colleagues in the panel for doing this with me. It has been a pleasure. I think as we wrap things up, if I were to highlight some key takeaways, I would say that adjuvant immunotherapy with pembrolizumab prolongs disease-free survival, especially in those cases of very high risk of recurrence. The gold standard for treatment-naive metastatic renal cell carcinoma is an immunotherapy-based combination. There are several individual patient and disease characteristics that determine the therapy combination. We talked about tumor burden, clinical symptoms, sites of metastasis, prognostic risk group. And finally, immune-related adverse events occur and can involve any organ in the body. The treatment depends on the time to onset, severity, and duration of symptoms. They require monitoring and symptom medication. And the severe cases often require systemic immunosuppression. Thank you, the panel, and thank you all for participating in this program.